It's my pleasure to introduce Emily Bergsland. Earlier you met Greta, who is, she's lucky enough to work, they're lucky enough to work together, frankly, as a team. And Greta touched on nutritional management of carcinoid syndrome. We talked a little bit this morning about octreotide and somatostatin receptors, but now we're all good friends up here. So now Emily's going to give us a more formal talk on carcinoid syndrome. Emily, welcome.
Okay. Well, first of all, thank you so much for inviting me. It's actually really, really nice to be able to do something together in collaboration. And I think it's really true. I think we're all in this together, and I have worked for many years with both George and Pam, and I think that it's a pleasure to be here today. I'm really happy to be able to do that. I am sorry, however, I've not been able to be here the whole day, and I have to leave a bit early this afternoon due to other engagements today. I was asked to talk specifically about carcinoid syndrome, so I'm going to assume a working knowledge of carcinoid and also the basic therapies that are out there. And I'm going to focus on the complications and the management of carcinoid syndrome. And I'm going to try to highlight, it's a lot of information, but I'm going to try to highlight what's known and what's unknown. I'll try to highlight what's controversial versus what's standard, and I'll try to highlight where the field is going in 20 minutes with some time for questions. So I'm going to briefly touch on just the basics of what carcinoid syndrome is and its management. And then I chose a couple of topics to address at the end that just either don't come up and should come up. For example, perioperative management or the risk of carcinoid crisis, but also some of the recurring themes that come up a lot, like refractory diarrhea in patients on octreotide. So I'm sure this is familiar to you by now. Carcinoid tumors, of course, are well-differentiated neuroendocrine tumors, and they're really categorized by site of origin, foregut, midgut, or hindgut. And actually, what's interesting is that site of origin influences the prognosis or the outcome with, for example, hindgut tumors or rectal carcinoids, for example, having a relatively aggressive course, as well as bronchial tumors, and thymic, compared to midgut tumors, which tend to have a relatively indolent course. In addition, you'll see that the ability to make hormones that cause a syndrome, some sort of symptom complex, also varies by location. And I would think the real classic pearl here is the fact that hindgut tumors, or for example, rectal carcinoids, simply don't make serotonin and don't cause carcinoid syndrome. But there are other syndromes, as you can see up here, and particularly the foregut tumors are known to make some interesting hormones and some other syndrome complexes. But I think it's something to keep in mind as we have our discussion today, because it's really not, this is not a uniform thing. It's not a one-size-fits-all syndrome, and you'll find quite a bit of variability from one patient to the next, one tumor location to the next, et cetera. So interestingly, this syndrome actually occurs in a subset of patients with carcinoid. So you can have a carcinoid tumor, it can be metastatic, but you don't necessarily have carcinoid syndrome. That is a complex of symptoms that are the result of hormone production. And usually these are hormone-mediated symptoms caused by the secretion of serotonin, but a number of other bioactive amines can cause these symptoms. And this is important to keep in mind because the main one we test for is serotonin and its derivatives in the form of urinary 5-HIAA. These symptoms can be episodic. They can be triggered by a variety of things, including exercise, stress, certain medications, certain foods. And in fact, many patients will find that their triggers might be different than a person sitting next to them. It's, again, very unique. And the symptoms similarly range from the sort of classic symptoms of flushing, diarrhea, wheezing, palpitations, chest pain, abdominal pain. The quality of the flushing can vary. Sometimes it's light pink, sometimes it's deep purple, sometimes it's sustained, sometimes it's brief. So this just gives you an idea of the general symptomology, but it's, as I said, it really varies from patient to patient, hormone to hormone. I want to mention that right-sided heart disease is a significant issue in some patients, and we'll talk about that more. And then pellagra is something that we don't see too much in our population and our sort of supplemented diets that we have in the United States, but it reflects a niacin deficiency, and that can have some skin findings, diarrhea, and dementia, but again, it's fairly rare. So serotonin is thought to be the main mediator of carcinoid syndrome, but again, I just want to remind you that there are a number of other mediators, and I think the details maybe aren't that important, but I think it just is to underscore that what we test for in clinic really is just a snippet and a snapshot, and it may be the relevant marker in a lot of patients, but it may not be the only marker or even the best marker in all patients. So that's something to keep in mind as we're moving through this presentation. Just a word on biochemical testing, and I apologize if this is redundant, but the main things we do in patients with carcinoid and certainly carcinoid syndrome would be chromogranin, serum chromogranin, and urinary 5-HIAA. And just to make sure you're aware of this, chromogranin levels actually are influenced by a couple things. One is that it is actually influenced by somatostatin analogs or drugs like octreotide. So ideally, you'd get your chromogranin done around the same time during if you're on LAR, you'd get it around the same time each month or every other month or every 4 months. Whenever you're getting it, it's drawn around the same time relative to the injection, ideally. Also, proton pump inhibitors can affect chromogranin levels, so ideally, patients would be off those for about a week before a chromogranin draw. Again, I think how much this really affects your management depends on the patient and the clinical setting, but it's something to be aware of. There are some other things that can affect chromogranin levels, and I've listed a few of them here, including renal insufficiency and pregnancy and some other situations. Now, urinary 5-HI is very dependent on what people eat, and I imagine in this community you guys are pretty educated about the dietary rules and restrictions for collection of urinary 5-HIAA, but it's not widely known, and I think a lot of patients spend all that time collecting their urine and don't realize there are a lot of foods they should be avoiding for 3 days prior to and then during the collection. And these foods are listed here, and they're foods that bananas, walnuts, avocados, caffeine, so no coffee for a few days. There are a few cold remedies that can be problematic. And so the idea is that basically you want to sort of clear the decks of anything that's going to be artificially increasing your levels of 5-HIAA to make sure the test is really reflecting the tumor production. Now, this is complicated, and I'm not going to ask you to memorize the enzymes, but I just want to point out that basically you have serotonin, which you can measure in the blood. That's converted to 5-HIAA, which is a metabolite. There are all these enzymes involved in the pathway. And I just want to point out that basically when we are collecting this, it's thought to be a little bit more of a reliable test for serotonin production overall, because serotonin levels in the blood vary very widely during the day. So they're kind of all over the map, whereas the urine collection tends to be a bit more reproducible. It does hinge, though, on this enzyme being operative and active in there. And again, in some situations, patients may have different metabolites that we're not picking up in the urine, or they may have tumors or situations where they're just not having this conversion from serotonin to 5-HIAA. So it reflects one of the pitfalls of this as a test, although overall it's excellent. It has a high sensitivity and a high specificity in patients with carcinoid syndrome. It's a good test, but not perfect. Interestingly, levels don't necessarily correlate with severity of symptoms. And I think certainly as physicians we've seen that, where we have patients with really high levels and not a lot of symptoms, and we have the opposite with people with pretty low levels of 5-HIAA who are very symptomatic. And there are very rare cases of people who look for all the world like they have carcinoid syndrome, but they aren't producing high levels of 5-HIAA. And again, that probably is due to something else going on in terms of hormones we're not assessing. There are a bunch of other hormone markers that I just want to mention because if you're Googling and out there reviewing websites, you'll see a lot of other markers come up, but practically speaking, they aren't necessarily very widely available, and they tend not to be used that much clinically. You might find certain doctors like certain tests, but overall, it's chromogranin and 5-HIAA that we test for. Now, in terms of management, I just wanted to just remind everybody a little bit about somatostatin, and again, this may be a little redundant, but I think it's important just to remember that octreotide, which is a widely used drug, is a man-made version of a hormone we all have in our bodies called somatostatin. And somatostatin actually wasn't identified that long ago. It was 1973, so not too long ago. It binds to 5 different receptors that are scattered throughout the body in various locations. And it's produced and acts locally to decrease basically hormone functions, both endocrine and exocrine, but it does a variety of things. It alters a lot of the GI hormones. It may also have some effects where it can slow cell growth, and that's something that will come into play in a few minutes when we talk about the anti-tumor effects of somatostatin analogs. But this hormone's around, we all have it, it's in our bodies, and that's there at baseline. This slide is complicated, but I want to just point out something here that I mentioned it binds 5 receptors, and the only point of this slide is these 5 receptors may have different functions, but the octreotide analogs that we use in practice are only hitting a couple of these receptors and not all of them. So that's a potential area of interest. And when we talk about where the field's going, people are interested in trying to get somatostatin analogs that might have different binding specificities when it comes to these 5 receptors. And the expression of these receptors may be tumor or tissue specific. So we know neuroendocrine tumors highly express these receptors. I'm sure many of you are aware of the use of octrea scans as a diagnostic test. That's a little radio-labeled octreotide, which is a somatostatin analog that goes to tumor-associated receptors. We know now that for sure that if we target these receptors, we have the potential to control some of these hormone-mediated symptoms and also potentially control tumor growth. There are 2 somatostatin analogs that are approved. Octreotide comes in a sub-Q form and an LAR form. This binds receptors 2 and 5. Remember that these don't necessarily bind all 5 receptors. And in the United States, it's approved for acromegaly, which is a growth hormone disease, and also carcinoid syndrome. Lanreotide's not approved for carcinoid syndrome, but it has been studied in this disease. It's not approved in the United States for carcinoid syndrome. And I just want to point out that, a good majority of patients have definite symptomatic benefit from these analogs, and these have revolutionized the treatment of carcinoid syndrome. I mean, prior to these being available, it was a very difficult disease to treat. And then you'll see around 40 or 50% of patients will have a nice reduction of their urinary 5-HIA levels, which is a biochemical response. So we know that they work. I wanted to just insert here, just in case it wasn't here this morning, that we also have data that octreotide delays tumor growth, and that was suspected for a really long time. But this is a study done in midgut carcinoids where, compared to placebo, you could see that the time it took to grow on average was 14 months in people on octreotide and 6 months in people off it. So this was the first randomized data that really proved that octreotide has anti-tumor effects. So that's not my topic today, but it sort of is nice because now we have a drug that not only can be used to control hormone-mediated symptoms, but also is a therapy in and of itself. So now there can be discomfort at the site injection. These are IM injections. They're a little tricky to actually do properly. Some patients experience altered glucose metabolism. Some people have GI symptoms, including loose stools and cramping and bloating. Now, this is the reason for using the short-acting version for a week or 2 before you go to the long-acting, because once the long-acting is on board, then there are no takebacks. So now on the bright side, the GI symptoms often attenuate over time, but there are some patients who really have intolerable side effects that are GI and they just can't tolerate octreotide long-term. It's pretty rare, but it can happen. Gallstones can happen in patients. It's usually sludging as opposed to symptomatic stones, but it is the reason why when patients are undergoing an elective surgery for another reason, we'll usually take the gallbladder out in anticipation of this potential problem with long-term usage. And the recommendations are evolving, but I'd say there's sort of growing enthusiasm for monitoring the thyroid function and vitamin B12 levels and potentially monitoring sugar periodically in patients on octreotide, just because we know that it's mimicking in higher doses this normal hormone somatostatin that does have very pleiotropic effects in the body. Okay, so what if symptoms persist? So I just want to mention a couple of things about this. So I think it's actually, I don't know how common it is, but it is, certainly does happen where patients will say they simply feel like they had a bum injection. It just wasn't in the right location. That just this month their symptoms weren't that well controlled. And I know there's been a big educational effort out there to try to help teach providers how to do these injections, which I mentioned are IM. There is the potential to not get it in the right place. And I think this is something to keep in mind. And some people will get a reaction to these injections over time, a local site reaction. There's also the possibility that you're just not on the high enough dose of octreotide, and that sometimes is a little challenge to sort out, but I would say that the most common thing we do in practice is we will just increase the octreotide. So if you start at 20, you go to 30, if you start at 30, you go to 40, or maybe you add some sub-Q octreotide just to see if that helps for breakthrough, and that's a good test to see if more is better. But I would point out that the approved indication for octreotide is up to 30 milligrams a month. So, when you start getting to these doses of 40 milligrams a month, 60 or even 120, which some people have used, that's beyond the normal indication. And we really don't have good data to guide us in terms of whether more is better. It's definitely done, and it may be helpful in selected patients, but it's one of these unknowns. Another bit of controversy surrounds the use of octreotide levels, and I wanted to mention that just because some people have pursued this, some people recommend it, some patients do it. And there are some data that over time, when you're on octreotide for a long period of time, that your blood levels may drop. But again, how to actually use this in common practice to titrate dose is a little bit controversial. In extreme cases where somebody really seems to be benefiting from octreotide, but there's some reason they're not tolerating, they're not getting enough octreotide with the IM injections, there are reports of patients getting it by sub-Q infusion. And then there's the question of, well, what about switching to another agent that might also be a somatostatin analog? And I would say that there's a real interest in this because patients do get refractory or have difficulty having perfect symptom control on octreotide. And the question is, what could we do? What's the next step after that? And I'm not going to go into this any detail, but I just want to mention there are lots of other agents that are out there in development, all sorts of combinations trying to inhibit various receptor combinations and hormones. And there are even, there's a product that's currently in clinical development right now that actually aims to inhibit one of those enzymes I showed you in the metabolic pathway to actually go right there to inhibit serotonin production. And that's in the works right now in clinical trials. This is an example of a drug that's gaining some traction, is now out there in trials, pasireotide. Now, this one, instead of just binding receptors 2 and 5, this one binds receptors 1, 2, 3, and 5. It doesn't hit receptor 4. Its binding affinity is somewhat different than octreotide for these individual receptors. And the idea here is that perhaps this might be used to give broader coverage, might be used to capture patients who are resistant to octreotide, or maybe it could be used ultimately, eventually instead of octreotide if it's thought to have better efficacy and a better safety profile. This is an example of some of the trials that are going on right now related to somatostatin analogs. There's a lanreotide study versus placebo that's looking at symptoms. There's a pasireotide study, which is the agent I just talked about, versus octreotide for people with uncontrolled symptoms on a somatostatin analog. And then there are a couple of studies looking at the anti-tumor benefits of these agents, including a lanreotide study, and also an octreotide study looking at interferon versus bevacizumab, which is a VEGF inhibitor, and its effects on progression. Okay, so refractory carcinoid syndrome, unfortunately, I don't have time to go over this in detail, and I hope that was covered in your first session today, but there are a variety of options, including adding interferon, going for a liver-directed approach. Chemo is sometimes used, although we don't have good data to support us and guide us. It's really of uncertain benefit. Peptide receptor radiotherapy, PRRT, not widely available in the US, but may be beneficial in some cases. But again, randomized trials are lacking. And then novel agents are really where there's a lot of interest, but we don't yet have good data, and we certainly don't have FDA-approved agents such as mTOR inhibitors or VEGF inhibitors for this disease. So I'd like to just finish up mentioning a few special topics then. For refractory diarrhea, I think oftentimes we worry about tumor progression, but I just want to remind everyone that there are actually other reasons why people may have refractory diarrhea when they're on octreotide. One is that octreotide itself can cause pancreatic insufficiency, meaning that some of the hormones, the exocrine hormones that the enzymes that the pancreas secretes are not being secreted in a proper way, and that leads to fat malabsorption and a very unique kind of stool. It's usually very foul-smelling. It can leave a ring around the toilet, and it responds to pancreatic enzyme replacement, which you take before meals and with snacks. So that's an important thing to keep in the back of your mind. Most patients know it when they have it, but that can be a useful addition to their regimen, is to add enzyme replacement. I mentioned pellagra. That's actually very rare, but I think Greta suggested this morning that patients consider being on a niacin supplement just to prevent this from happening, but that can be a cause of diarrhea. Occasionally people, if they've had a lot of surgery, just having been sort of reconstructed and having had bowel removed, those patients will have what's called short bowel syndrome. They just won't be functioning in a proper way and will have diarrhea. That's a little harder to tackle, but sometimes binding resins like cholestyramine can be helpful. Sometimes simple things like Imodium or even using tincture of opium can be helpful for patients. And then there are some other things that people have tried, serotonin receptor antagonists, including ondansetron, which is Zofran, a commonly used anti-nausea medication, may have benefit in some cases. Carcinoid crisis, think of this as just a big surge of hormones in someone with a hormone-mediated syndrome. The problem is a big surge of this in the setting of stress. So for example, during surgery or sometimes by embolization. You know, if you had a liver embolization, in theory, it could be anything that caused you to be horribly stressed, including exercise could do this, but in unique settings. But this is sort of very high swings in blood pressure or low blood pressure, irregular heartbeats, wheezing, flushing, shortness of breath, and this actually can be a really difficult problem and can be life-threatening. And this is the reason why we generally recommend patients with carcinoid syndrome have it mentioned on a MediAlert bracelet. So if you are in a car accident or you end up in the emergency room or you need emergency anything, the providers are aware of this risk of carcinoid crisis. Octreotide is the mainstay of therapy, but the best thing to do is to prevent this. And I would say, briefly, the idea is if you're going to have surgery, for example, of any type, including something that's elective like plastic surgery or, if you had some extensive dental surgery that needed to be done, you would want to make sure that your doctor has talked with somebody about it, that has thought about the anesthesia that's going to be used. For big operations, even embolizations, we usually will use an octreotide drip during the procedure. And in some cases, patients are admitted the day before to get started with fluids and an octreotide drip. So I think in centers that are familiar with this, you can prepare for it and be ready for it and hopefully avoid any complications. But you want to avoid a situation where no one's thought about this potential. That's when there can be real problems. I wanted to mention that there are other medications that sometimes are used perioperatively if somebody's having a crisis, because those actually link back to people having sort of unusual symptoms like wheezing, et cetera. But we sometimes using a medicine that reduces anxiety can help with some of the stress-related associations or release of serotonin. Histamine blockers, simple things like Benadryl and cimetidine and ranitidine can be helpful. Bronchodilators sometimes can be helpful, and then there's some more less commonly used drugs that can be used in selected cases. But the point is that sometimes we have to be really creative with patients who simply don't have good control of their symptoms with octreotide alone. Carcinoid heart disease is not as uncommon actually as you might think. This actually affects, as an initial presentation, some of the old data suggested 20% of patients would have carcinoid heart disease, and over a lifetime, up to 30 or 40% of patients may be affected. This is basically due to the serotonin causing fibrosis of the valves on the right side of the heart, so the pulmonic and the tricuspid valve. People present with heart failure, so they often will have very swollen legs, a big liver. They can be really, really tired. They can find it's just hard to get around. They don't have the exercise tolerance they had before. And it's easy to diagnose on an echocardiogram. You can tell very readily that there's carcinoid involvement, very classic symptoms. And in this case, the people with the higher 5-HIA levels probably are at greater risk. I wanted to just point out something that you may know already, but you know, if you have a tumor in the small bowel, and it releases serotonin, it can cause local fibrosis, and that can cause problems locally with bowels not functioning well. But any serotonin that's made from that local tumor gets sent to the liver where it's metabolized. And so patients with small bowel tumors tend not to have systemic effects from those hormones unless they have tumors in the liver. And then those liver tumors, if they make serotonin, then dump it directly into the inferior vena cava, which then goes back to the heart. And the first part of the heart to see those high serotonin levels would be the right side. Then it goes to the lungs, and in the lungs, actually, there's an enzyme that can convert it to 5-HIA, and so you're not getting usually the high levels of serotonin on the left side. So it's the right side of the heart that gets fibrosed, and that's shown here, where basically it's the pulmonic and the tricuspid valve that's the problem. So the bottom line is that to look for this, to do the echocardiogram when there's any evidence of heart failure. Diuretics, so water pills, things that make you pee a lot, can be amazingly effective in improving the symptoms. They're not going to reverse the fibrosis, but they can do a great job of making you feel better. And I found that just getting a cardiologist on board who's familiar with the syndrome, who knows how to manage it, can make a huge dent in the symptomology associated with this. But an important thing to keep in mind is that given the very long survival in many patients with carcinoid and carcinoid syndrome, sometimes replacing the valves, fixing the valves that are damaged is actually the right thing to do. It's a big operation, but it can be very helpful long-term in terms of quality of life and outcome. And then finally, I wanted to just mention Cushing syndrome. This is a really unusual syndrome. We only see it, mostly we see it in bronchial carcinoids. It can be seen in other ones too. But this is not due to serotonin production, it's due to ACTH production, which is adrenocorticotropic hormone, which leads to cortisol excess. And this is very problematic, and it can lead, in its extreme cases, it can lead to very difficult problems controlling blood pressure, diabetes, weight gain, depression. Obviously, the key thing is to control the underlying disease. If you could treat the tumor effectively, you would generally resolve this problem, because this is tumor-associated ACTH. So you can try a somatostatin analog, but these don't always respond to somatostatin analogs. Sometimes we use agents to actually go to the production pathway of cortisol. Cortisol is made in the adrenal glands. So this ACTH is basically going to the adrenal glands to tell the adrenal glands to make cortisol, and we can use medicines that interrupt that production, and that they're listed here. But again, it sounds extreme, but in selected patients, sometimes what we ultimately end up doing, especially if we can't eradicate the tumor and it's still there, we will remove both adrenal glands so there's no more cortisol production, and that actually can make people feel way better. They do need to be on lifelong steroid replacement because they no longer have their adrenal glands to make cortisol when they need it. But it's an extreme, but often a very helpful maneuver for people who are really symptomatic from Cushing syndrome. So with that, I wanted to end, and I wanted to just sort of reinforce that when we're sort of talking about treatments in the clinic, really what we're talking about in patients with carcinoid syndrome is discussing treatments, both keeping in mind the idea of the symptoms they have, but also whether or not the tumor's growing on the scans. And so both of those are a valid reason to be changing therapy or adjusting therapy in patients with carcinoid syndrome. Thank you so much.